Welcome, everyone. My name is Warren Kinghorn, co-director of the Theology, Medicine, and Culture Initiative at Duke Divinity School. And on behalf of Theology, Medicine, and Culture and our event co-sponsors, the Duke Divinity School Office of Black Church Studies, the Purpose Project at Duke, the Keenan Institute for Ethics, and the Trent Center for Bioethics, Medical Humanities, and the History of Medicine, it's my great pleasure to welcome you to the inaugural Richard Payne Lecture on Faith, Justice, and Healthcare, featuring our honored guest and awardee, Professor David Williams of Harvard University. The Theology, Medicine, and Culture Initiative, yes, that's right. The Theology, Medicine, and Culture Initiative seeks to connect the world of healthcare with the world of Christian faith and practice, and seeks to renew healthcare by equipping clergy and chaplains and healthcare practitioners to envision and to act toward just, faithful, and dignifying practices of healthcare. Distinct among seminaries and divinity schools, we offer formal programs for the theological formation of healthcare students and practitioners, both in the form of our residential Theology, Medicine, and Culture Fellowship and the Distance Hybrid Certificate in Theology and Healthcare program. We would invite all of you to learn more about our work in the information table in the foyer. Dr. Richard Payne, about whom we'll hear more in just a minute, was for many years a generous encourager and co-laborer in our work. I first met Dr. Payne as a Duke psychiatry resident in 2004, when he was named director of the Duke Institute on Care at the End of Life. And I personally benefited from his encouragement and friendship and wisdom as we later became faculty colleagues and co-teachers in the Theology, Medicine, and Culture Initiative. It's an honor for me and for us to celebrate Dr. Payne's life and legacy tonight in the presence of so many of his friends and his family. I'd now like to recognize Dr. Sally Kornbluth, the Provost of Duke University, who will extend a greeting. We'll then watch a brief video marking Dr. Payne's life and legacy, after which Dr. Patrick Smith of Duke Divinity School will introduce our speaker. Thank you.
Good evening, everyone. As you just heard, I'm Sally Kornbluth. I'm Provost here at Duke, and it's indeed a pleasure to be with you here this evening as we welcome Dr. David R. Williams and celebrate the legacy of Dr. Richard Payne. I offer my thanks to my colleagues from the Theology, Medicine, and Culture Initiative for organizing the Richard Payne Award and Lecture and for bringing us all here together tonight. I'd also like to thank and recognize Dr. Payne's widow, Ms. Terry Payne, who is with us tonight, as well as other members of his family, some of whom are here with us in person. And some who are joining us virtually. So thank you all for being here. The Richard Payne Award and Lecture aims to highlight and honor academic, clinical, and lay leaders whose work embodies Dr. Payne's spirit of caring for the whole person. This award sits at the intersection of academic research, clinical practice, and community engagement. In doing so, it highlights work that aligns with the university's highest aspirations. That is, with our vision of Duke as the home of bold thinkers whose scholarship advances our understanding of the world. It supports the well-being of others and advances equity in our own community and beyond. This type of work is by its very nature deeply interdisciplinary and collaborative. It requires scholars to engage with and integrate with materials and methods from a range of disciplines, as Dr. Payne did so thoughtfully in his own work. At Duke, we believe deeply in the power of interdisciplinary education and scholarship to address complex challenges and to improve the human condition. We foster and celebrate this work and the people who do it because we know that this is essential to addressing the challenges of the 21st century. Through its work connecting the traditions of Christian thought and practice with contemporary medicine, Duke's Theology, Medicine, and Culture Initiative is an outstanding example of interdisciplinary connections to support human health and well-being. So again, I thank you for being here tonight to celebrate Dr. Payne's legacy and to learn from Dr. Williams. It's now my pleasure, I guess there's a film next, and then we will turn it over to Professor Patrick Smith. So thanks very much.
We are dealing with people and people who are connected in a community, and those are important values that need to be upheld as we try to build the highest quality systems of healthcare that care for persons with illness, not just care for diseases.
Richard Payne was a big guy. A big man, not just physically, but in terms of his heart, in terms of his caring, his compassion.
He had this deep respect for the human spirit. I was so admiring of him because he lived that. He lived that as a physician, he lived it as a teacher, he lived it as a mentor. And I think he inspired all of us.
Dr. Payne was a giant. He practiced the art of medicine, even more so than the science of medicine. I believe that's what set him apart.
He was a gentleman, he was a scholar, he was a whale of a physician. He loved his patients.
All he wanted was to do what was right, what was in the best interest of the patient in front of him, the student in front of him. That's what he sought, and that's what he leaves us.
People are people. They're not a collection of molecules and tissues and organs, right? So we have to understand what that person with the disease or illness really wants to accomplish.
It was important for us to have someone of his stature. He was the John B. Francis Chair.
John B. Francis was an early member of our board and a remarkable man, much like Richard, actually.
And in the chair, we wanted someone who had the highest professional standards, of course, but also someone who had empathy for those in need or in pain or in distress of any sort, and those really concerned with ethical problems, particularly in medicine. And I think Richard certainly exemplified all of those qualities.
We knew the kind of depth and conviction, integrity, dignity that he would bring to his work. He challenged us, he inspired us many times over.
When he joined the center, he was in his early 60s and, very physically vibrant and healthy. But I think it was a place in his life. He was thinking about this third chapter in life and what would that be. And I think it was maybe a match made in heaven, literally.
Access to the highest quality of care should be accessible to everyone, not just a privileged few.
The most excited I would see him get was about our duty to make sure that the underserved were not forgotten.
Richard and I exchanged more conversation about justice in the area of medicine, medical care, and disparities of care than probably any other topic.
I think that his legacy will also be that he touched lives through his family, through the people that he has loved, and through his God.
He was a faith doer in terms of integrity, ethics, honor, sensitivity, caring, compassion, all those virtues he lived those out on a daily basis.
You know, he was so loved and so admired that it'll take a while for us to heal from the loss. He would want us to go on. I know he would. He'd want us to be stronger than ever.
Cherish those memories and cherish that there was such a man named Richard Payne that walked upon the earth.
So very fitting. Good evening. Now it's okay, I come from a call and response tradition, so say good evening, you say. Great, it's good to see you all here. My name is Patrick Smith, and I must say that I am delighted for this moment and even more excited about the occasion for which we have gathered here on this evening. Thank you, Dr. Kinghorn, also Provost Kornbluth, for getting us started. I'm also grateful to see so many of the Payne family members here in attendance. And to echo Provost Kornbluth, we are thrilled that Mrs. Terry Payne is with us this evening. Yes. And those of you who know of the Payne's partnership over the years know that we could not celebrate Rich's legacy without Mama Terry, right? Dr. Richard Payne, Esther Cauliflower Professor Emeritus of Medicine and Divinity, was an internationally esteemed pioneer in pain relief, palliative care, oncology, and neurology. He joined the faculty of Duke Divinity School in 2004 as director of the Duke Institute on Care at the End of Life, the institute that predated and paved the way for the Theology, Medicine, and Culture Initiative. Over the course of his career, Dr. Payne helped to lead a number of prestigious institutions and academic societies. Yet his scholarship and academic leadership never displaced his central commitment to care for people. Dr. Richard Payne not only identified the deep healthcare disparities and increased incidence of mortality that exist between various groups that are produced at the intersection of race, gender, and class, he went further. Dr. Payne did not hide behind the security of an empirical researcher accumulating the facts of the matter only. As important as these data are, he went further. Dr. Richard Payne did not simply document the cold, barren, personal statistics of disparate treatment in healthcare that ultimately dehumanizes people. He went further. Over the years, his work has humanized the dehumanized. His work has given voice to people who are all too often neither seen nor heard. His work inspired us to have eyes to see and the plight of those disinherited folks, and ears to hear the faint and sometimes haunting cries of those from the margins. He worked for justice in healthcare and in health outcomes. Indeed, Dr. Payne consistently aligned his scholarly work with his devotion to those he was called to love and serve, from members of his family to his patients, from his church to his academic colleagues and his students. In particular, Dr. Payne found creative ways to bring together his academic work and his dedication to justice and equity in healthcare that was informed by a deep and profound faith. Something that was deeply important to Dr. Payne was holding together science, medicine, faith, and spirituality in caring for people. He was one who brought together care of the body and care of the soul. And many of us in this room who have worked with Dr. Payne on projects have described him as one who was deeply committed to be a minister of the body and a physician of the soul. Now, some may take this phrase, minister of the body, physician of the soul, as being inverted, right? Shouldn't it be physician of the body, minister of the soul? But this phrase reflects the deep commitment of holistic care that Dr. Payne embodied and exemplified in his work. On one side, Dr. Payne challenged faith communities to see the vital connection of body and soul and the kind of holistic care that is needed for both living well and dying well enough. Any would-be care for people must address their material conditions, lived experiences, and embodied circumstances. As he would want to remind us, there are no spiritual practices that can be engaged apart from the body. On the other side, Dr. Payne reminded professional healthcare workers that we are people before we are patients. When professionals journey with people who need care and with their families, there must be attention to notions of spirituality and various expressions of faith for those to whom these issues are important. Dr. Payne embodied in his life and his work this ideal of being minister of the body, physician of the soul. The Richard Payne Award and Lecture aims to highlight and honor academic and lay leaders who, in their work and research, embody Dr. Payne's spirit of caring for the whole person. And so it is a great honor and privilege for me to announce our inaugural recipient and speaker of the Richard Payne Award and Lectureship in Faith, Justice, and Healthcare. Dr. David R. Williams is the Norman Professor of Public Health and Chair of the Department of Social and Behavioral Sciences at the Harvard Chan School of Public Health. His prior faculty appointments were at Yale University and the University of Michigan. He holds master's degrees in public health and divinity and a PhD in sociology. An internationally recognized social scientist, he has authored more than 500 scientific papers, and his research has enhanced our understanding of the complex ways in which socioeconomic status, race, stress, racism, and health behavior can affect health. The Everyday Discrimination Scale that he developed is the most widely used measure of discrimination in health studies. He has also studied the association between religious involvement in health, directed a national study on forgiveness in health, and co-edited a 2015 book on forgiveness in health. Dr. Williams is an elected member of the National Academy of Medicine, the American Academy of Arts and Sciences, and the National Academy of Sciences. He has received distinguished contribution awards from the American Sociological Association, the American Psychological Association, and the New York Academy of Medicine. He has been ranked as the most cited Black scholar in the social sciences worldwide and as one of the world's most influential scientific minds. He has played a visible national leadership role in raising awareness levels of inequities in health, including serving as staff director of the Robert Wood Johnson Foundation Commission to Build a Healthier America and a key scientific advisor to the award-winning PBS film series Unnatural Causes: Is Inequality Making Us Sick? His research has been featured in the national print and television media and in his TED Talk. He is a recipient that is worthy of this award. Would you join me in welcoming Dr. David Williams to the platform this evening? This award here.
It's truly an honor to be here and to learn even more about Richard Payne. I confess that I did not know him personally, but 2 weeks ago I was telling a Duke alum that I was going back to his alma mater, and he said, "What are you going for?" I said, "Well, I have to give the Richard Payne address." And he said, "I know him. I know his family well." And Andy Burness, my friend of many years, close family friend, gave me so many stories about the kind of person Richard, his wife, who I met when I walked in tonight, and family was, that it even filled me with a greater sense of awe that I should receive this honor. And so I'm just truly honored to be here, and thank you very much. We have a lot of territory to cover, and so I'm going to jump right into my talk so that we have time for discussion. Social inequities in health, challenges and opportunity for contemporary Christians. There are large racial ethnic differences in health in the United States and around the world. I'll give you one example from the United States: infant mortality, the chance of a baby dying before its first birthday. You can see the death rates for African Americans or blacks, Native Hawaiians or other Pacific Islanders, American Indians and Alaska Natives is much higher than that of whites. And just to make the point that this is a global problem, I'll pick one other example: infant mortality by ethnicity in England and Wales. And you can see that Pakistanis, blacks from Africa, Bangladeshis, blacks from the Caribbean, and Indians have markedly elevated infant mortality rates than whites. And I have data from countries throughout Latin America, from Australia, New Zealand, South Africa, that tell the same story. And COVID-19 has highlighted and showcased these disparities and really worsened health overall in the United States and widened the racial gaps in health. So here are age-adjusted odds ratios for populations compared to the white population. If you look at the top line, the indigenous or Native American population, they have a death rate from COVID-19 that was 2.2 times higher than that of whites, Latinos 2.4 times higher, African Americans twice as high, Pacific Islanders 2.6 times higher. Sometimes when people see, and these were the deaths through 2021, there's more than a million deaths as of today. But sometimes when people hear of the rates being higher, they think that the number of people is greater. And so I actually showed the actual numbers through March 2, and you can see the majority of people who died were white. There's one study published last year that found as a white population in the United States learned that there was elevated risk of death for populations of color, they reduced taking COVID precautions because they assumed they were no longer at risk. This is the impact of COVID-19. Life expectancy is how long the average person lives, life expectancy at birth. And you can see from 2019 to 2020, we saw a decline in life expectancy larger than we have seen since 1944. Life expectancy declined for Hispanic males by 3.7 years, 3.3 for African American males, 2.4 for African American females, 2 years for Hispanic females, and over 1 year for white males and white females. We have not seen declines of this magnitude in over 70 years. And these racial inequities in health that I've just shown you 2 examples are persistent over time. One illustration of this persistence is readily evident if you look at life expectancy at birth for blacks and whites from 1950 to the present. We have data only on blacks and whites that go back that far. And what you can see is in 1950, the average white person lived 8 years longer than the average African American person. There's good news in the data. Over time, up through 2010, life expectancy is increasing for whites, it's increasing for African Americans, and the gap is actually narrowing. So there's a 4-year gap in 2010 compared to an 8-year gap in 1950. However, these disparities are quite large, and it actually takes a long time to see progress. Look at the life expectancy of whites in 1950, 69.1 years. And let's ask, how long did it take for the health of African Americans to catch up to the life expectancy that whites had in 1950? 1990, 40 years later. 2 groups living in the same society, that's the magnitude of the difference. And look at the impact of COVID with the 2020 life expectancy rates. You see they are lower in 2020 than in 2010 for both whites and African Americans, and the gap has widened. There was a 4-year gap in 2010, a 6-year gap in 2020. What drives these racial inequities in health? Well, I'm a sociologist, and I know that socioeconomic status, income, education, occupational status, wealth, is the single biggest driver of access to virtually any desirable good within society, and that's true around the world. There are large inequities in health in the US and globally by socioeconomic status. And race ethnicity is strongly related to socioeconomic status. Let me illustrate that with data on median household income, national data for the United States from the US Census Bureau. I'm presenting the data in a way you can't miss the point. So I'm standardizing on the household income of white households as $1. And for every dollar of household income white households receive, Asian households receive $1.23. 2 points to keep in mind to interpret that data. One is Asian households are more likely to be multi-generational than any other racial group in the United States. So more persons contributing to household income. If I were using a per capita measure of income, you would see whites with the highest per capita measure of income. Asian households of almost 70% are immigrants. They've come to the US with high levels of education. But let's look at historically disadvantaged groups. For every dollar of income white households receive, Native American households receive 59 cents, and African American households receive 59 cents. What is stunning about that 59 cents figure, that is identical to the black-white gap in income in 1978. You heard me correct, I did not misspeak. 1978 was the peak year of the narrowing of the black-white gap as a result of the civil rights policies of the 60s and 70s and the war on poverty of the 60s and 70s, and the gap was reduced to 59 cents. And in 2018, it is 59 cents. Has it been stuck at 59 cents over time? No, it got worse throughout the decade of the 1980s. And it was in the mid-1990s it got back up to 59 cents, and it's a penny up and down since then. The important take-home point right now is that racial inequities are much larger than most of my students think and that most Americans think. There's been a lot of talk and a lot of assumptions about progress, but we have not made as much progress as most people think. And as bad as the income data show, they dramatically understate the racial gap in economic status. What do I mean when I say that? Well, income captures the flow of resources into the household. It tells us nothing about the economic resources that households have to cushion shortfalls of income. We get that from data on wealth, home equity, savings, investments. And according to the Federal Reserve Board, for every dollar of wealth that white households have, black households have 10 pennies, and Latino households have 12 pennies. And when you are low in income and low in wealth, you can be one paycheck away from being homeless, one paycheck away from being able to feed your family. And so although we've all been in the storm of the pandemic, we're not in the same boats. And some boats are better equipped to weather the storm than others. When my career started, most researchers thought that racial ethnic differences in health were simply a function of socioeconomic status. So if, for example, you looked at blacks and whites at the same level of income or education, race would no longer matter. We now know that life is more complicated. Let me illustrate that with national data for the United States. Life expectancy at age 25. At age 25, how long will the average person live? Well, the average white person will live 5 years longer than the average African American. So there's a 5-year gap by race. But the power of socioeconomic status. Whites with a college degree or more education will live 6.4 years longer at age 25 than whites who have not finished high school. Importantly, the socioeconomic gap is larger than the racial gap. And within African Americans, the best of African Americans, those with a college degree or more education, will live 5.3 years longer. Again, the gap within each race is larger than the racial gap. So should we abandon collecting data by race and only focus on socioeconomic status? I would say not so fast. Why? Because race matters at every level of income and education. I'm showing you the education data only in terms of time, but the same is true in the income data. Because whites with the lowest levels of education live 3.1 years longer than African Americans who are high school dropouts, and the gap widens as education increases. And remember, this is national data for the United States. And here is a stunning statistic. The best off African Americans, those with a college degree or more education at age 25, have lower life expectancy than whites with a college degree, lower life expectancy than whites with some college education, lower life expectancy than whites who have graduated in high school. So what do these data tell us? They tell us profoundly that there's something about income and education that matter for your health regardless of your race. But there's something else about race that matters even after we've taken income and education into account. And so researchers have been asking empirically for the last 25 years or so, could racism be a critical missing piece of the puzzle to understand the patterning of racial disparities in health? So I want to talk about the house that racism built, and I want to illustrate the ways in which we now have evidence that racism adversely, directly impacts health. So what do I mean when I use the term racism? I think of racism as first and foremost as a system that categorizes and ranks, devalues and disempowers, and differentially allocates resources to some groups versus others. It's premised on an ideology of inferiority, that some groups are inferior and some are superior. It leads to negative attitudes and beliefs, stereotypes and prejudice, and it leads to differential treatment, discrimination by individuals and social institutions. So there are multiple mechanisms by which racism operates. And one of those mechanisms is structural or institutional racism, or some people use the term systemic racism. This is a 2001 paper I wrote with one of my students, where we argued that racial residential segregation, policies developed in the late 19th century, firmly established in the United States in the 20th century, is a fundamental cause of racial disparities in health. This is a book written by John Sell. I don't know how many of you know him. He's a famous Duke historian. His entire career was in the Department of History here at Duke. He's written 4 books. This is his most influential book. And it is about the origins of segregation in the US South and South Africa. One of the intriguing points he shows is that the framers of apartheid in South Africa got the idea of apartheid from us. They looked at how well segregation was working in the United States in the early 20th century, and they said, brilliant, we could implement that in our country. Importantly, he argues that residential segregation was one of the single most successful policies of the 20th century in the United States. And you're saying, what does segregation have to do with anything? Well, let's talk about how segregation works. Imagine segregation as a burglar at midnight. It enters a community, and once it shows up, valuables disappear, like quality schools and safe playgrounds and access to good jobs and a healthy environment and safe housing and access to high-quality transportation and access to high-quality medical care. Research in the United States indicates that all of these valuables vary by where you live, vary by your zip code, vary by your neighborhood in the United States. And it's not by chance, it's a plan. What's the empirical evidence? Here is William Julius Wilson and Robert Sampson, 2 of America's most eminent sociologists, both of them colleagues of mine at Harvard. They studied the 171 largest cities in the United States, and they said because of segregation, there's not even one city where whites live under equal conditions to those of blacks, and that the worst urban context in which whites reside is better, considerably better, than the average context of black communities. Now, you say that's a 1995 paper. Have things gotten better? So let me draw on another good friend of mine, Professor Dolores Acevedo Garcia at Brandeis University. She has done something amazing. She has created the Neighborhood Opportunity Index, ranking every county in the United States on 29 different indicators of access to opportunity for kids, like the quality of elementary schools and the high school graduation rate, and the home ownership rate, and the rate of employment, and access to a healthy environment, and access to resources for health, like green space, healthy food outlets. At 29, I just list a few under the 5 broad categories that she uses. And here, in a 2020 paper, she asked a simple question: which children live in the very low and low opportunity neighborhoods in the 100 largest metropolitan areas in the United States? And what did she find? 67% of all black children, 58% of all Latino kids, 53% of all Native American kids, compared to 1 in 5 white and Asian kids, live in very low or low opportunity neighborhoods. On the opposite end, almost 2/3 of all white kids and Asian kids, and only about 1 in 5 African American and Latino kids, live in high and very high opportunity neighborhoods. In fact, what research indicates is opportunity at the neighborhood level that drives even the racial inequities we see in income and education. Let me show you the evidence. David Cutler, an economist at Harvard University, with his colleague Ed Glazer, did a national study in the United States using fancy econometric models I cannot even fully describe. But they are able to show statistically that if you could eliminate residential segregation in America, you would completely erase black-white differences in income, in education, and in unemployment, and reduce black-white differences in single motherhood by 2/3. All of those striking differences are linked to opportunity at the neighborhood level. You want more evidence? One last study. Rash Chetty, another Harvard economist, he has done an amazing intergenerational analysis. He has gotten access to all the census data for over 2 decades. And what he has asked, the question he's asked, is an intergenerational question. Let's compare black and white children who start out life at the same level of household income. How are they doing in the next generation? And what does he find? In 99% of census tracts in America, black boys have lower earnings than white boys, even taking parental income into account. Why? Because they're lazy? No, they live in neighborhoods that differ in access to opportunity. Black boys do as well as white boys if they are in neighborhoods with good resources, but that's not true in 99% of the census tracts where they reside. What does this tell us? It tells us that the striking inequities we see in the United States do not reflect a broken system. Instead, it reflects a carefully crafted system, functioning as planned, successfully implementing social policies, many of which are rooted in racism. The inequities are not accidents, are not acts of God, they're not random events. They illustrate the ways in which racism, through upstream structural mechanism, has produced a truly rigged system in the United States. And research finds, my research and that of others, shows that when you are low in economic status and you live in disadvantaged, segregated neighborhoods, you have higher levels of exposure and greater clustering of economic stresses and psychosocial stresses and physical and chemical stresses. So I've talked about structural racism and how it impacts health. Well, there's also racism at the individual level, individual discrimination. And these experiences can be an added source of stress. Martin Luther King said, "The discrimination is a hellhound that gnaws at Negroes in every waking moment of their lives, telling that the lie of their inferiority is accepted as a truth in the society dominating them." If that's true, and it's a hypothesis that could be tested, what's the impact of discrimination on the health of African Americans? So I decided to develop measures to capture exposure to discrimination. And one that was mentioned in the introduction is the everyday discrimination scale. Not the only one, but the most widely used one. And what is striking, it doesn't capture the big stuff. It's just the little indignities. Treated with less courtesy and less respect, receive poorer service than others at restaurants or stores, and people act as if they think you are not smart, or they're afraid of you, or they think you are dishonest. Little indignities. And just to illustrate the impact, I'll showcase the work of one researcher, Professor Tenney Lewis at Emory University. Every line on this slide represents a different outcome in a different peer-reviewed paper, linking everyday discrimination, elevated levels, to outcomes. High levels of everyday discrimination predicts coronary artery calcification, predicts inflammation, predicts elevated blood pressure. Pregnant women who report everyday discrimination give birth to lower birth weight infants. The elderly who report everyday discrimination have more rapid declines in cognitive function over time. It predicts poorer sleep. In one study, elevated levels of those little indignities adjusted for other confounders is an independent predictor of death. These experiences are literally killing people prematurely. Predicts higher levels of visceral fat, shorter telomere length, arterial stiffness, just a broad range incident cardiovascular events linked to exposure to the stress of discrimination. And what research is finding, that the stress of discrimination on top of the physical and chemical and psychosocial stressors are literally leading African Americans and other disadvantaged groups to age more rapidly in the United States. There's studies looking at telomere length, there's studies looking at biological clocks that find at the same chronological age, African Americans compared to whites at the same age are 10, in some studies 7.5 years older, in some studies 10 years older. Well, it's very simple. Your age doesn't only capture how long you've lived. If you live in a bad environment, your age is also capturing how long you've been exposed to bad environmental conditions and how physiologically compromised you have become as a result of those exposures. And so while the CDC shows us, and I'm showing you just blood pressure, but if you look at most of the chronic illness, African Americans demonstrate an earlier onset of disease. Look at age 50 to 64. 61% of African Americans have hypertension compared to 41% of whites. So I've talked about one upstream, and by the way, segregation is not the only upstream mechanism of racism, but it's one we will talk about. I've talked about individual racism, but then there's also racism that is deeply embedded in our culture, our assumptions of each other, the stereotypes and stigma and implicit and explicit biases that we have. Negative stereotypes about race remain deeply embedded in American culture. There's a lot of evidence for this. And there's evidence that it actually affects how we relate to each other, including how providers treat patients within the healthcare system. The Unequal Treatment Report, published in 2003 by the National Academy of Medicine, documented an overwhelming pattern. I was honored to serve on that committee. I'm part of a group working for March of next year to look at everyday unequal treatment 20 years later, to ask the question, how much progress have we made in the United States? What the study found, and this study was requested by the United States Congress, was when African Americans and other minorities enter healthcare contexts in the United States, does their race determine the quality of care? So it was not about access to care, it was given access. Are there differences in quality? And the answer was a resounding yes. Across virtually every therapeutic intervention, from the most simple to the most complicated, African Americans and other minorities receive poorer quality care than whites. Just give you one study suggesting the problem continues. This is a study of 1.8 million hospital births in Florida between 1992 and 2015. When cared for by white doctors, black babies are 3 times more likely than white newborns to die in the hospital. The disparity is cut in half when black babies are cared for by a black doctor. This study doesn't tell us the reasons, but it gives us a striking disparity that we need to understand. So I've talked about the problems. What can we do? Well, we need to build more health into the delivery of medical care. One of the things we need to do is to ensure access to care for all. So that's the beginning step, ensuring access to care for all, and we have evidence that that will make a difference. Second, we need to diversify the workforce to meet the needs of all patients. I'm going to share with you findings from a randomized controlled trial, highest quality of scientific evidence. It was done in Oakland, California. They took 1,300 African-American males, sent them to a Saturday clinic. When they got to the clinic, they were randomized to either be treated by an African-American physician or physician of another race. And what they found was that men who saw a black doctor were more likely to talk about other health problems, more likely to do the screening for diabetes, more likely to get the flu vaccine, more likely to do the screening for cholesterol. So much more engagement with the entire healthcare system and benefiting from that visit when there was racial concordance. We face a challenge in the United States. In the mid-1960s, 2.9% of all practicing physicians were black. In 2019, 5% of all practicing physicians are black, 6% Latino, 0.3% Native American. There were fewer African-American males in the first year of medical school in 2014 than in 1978. We have a long way to go. I have some good news. Another study from Northern California that looked at disparities in treatment and outcomes for persons with HIV/AIDS. There was disparity in the receipt of antiretroviral therapy, in self-efficacy, and the patients following through and doing what their provider wanted to do, and with the medication actually working, producing the viral suppression that was desired. And the researchers reanalyzed their data. They had administered a cultural competence scale. And they found that although there was disparities overall, when cultural competence was high, regardless of the race of the provider, there were no racial disparities. So what was cultural competence? There was a 20-item scale. I'm going to share with you 7 of the items. You'll get a sense of what those providers were like. Providers high on cultural competence are providers who agreed that family and friends are as important to health as doctors. Providers who said social history contributes to how they care for their patients. Providers who said they were familiar with the lay beliefs their patients had. Providers who said they asked their patients about alternative therapies they use. Providers who said they find out what their patients think is the cause of their illness. Providers who said I involve patients in decisions about their health care. So what emerges is a provider who respects their patients, who engages them in conversation, who listens to them, who works together cooperatively with them, and when those conditions existed, there were no racial disparities in health. What else do we need to do within the healthcare system? We need to provide care that addresses the social context. The World Health Organization asked the question, what do we accomplish if all we do is treat illness and send people back to live in the same conditions that made them sick in the first place? Now, healthcare providers do not have to become social workers, but there are a broad range of strategies by which the healthcare system can integrate social care into the delivery of healthcare. And this is a recent report from the National Academy of Medicine that lays out all of these models that are working right now in the United States to do this. Strategy number 2, in addition to what we do within the healthcare system, we need to identify supportive and protective factors and resilience resources for populations that are suffering. Let me give you one dramatic example of the power of social relationships and its protective benefit in terms of health. Gene Brody is a researcher that has been studying African-American adolescents in rural Georgia. He measured discrimination among these teens at age 16, 17, and 18. By age 20, I didn't say age 40, I didn't say age 30, by age 20, those teens high on discrimination as a teen have higher levels of stress hormones, cortisol, epinephrine, norepinephrine, blood pressure, inflammation, and weight by age 20. However, among those African American kids who were embedded in good social relationships with their parents, their teachers, and their peers, there was no relationship between exposure to discrimination and biological dysregulation. The power of social ties being a protective resource. a national study finds that higher levels of discrimination for African Americans leads to higher levels of depression. However, 3 aspects of religious engagement, higher levels of religious attendance, receiving support from fellow members of your congregation, and seeking religious guidance in everyday life, each of these reduce the negative effects of the stress of discrimination on their mental health. And the third one, I'm going to Canada and looking at the First Nation community in Canada. At the time of the study, First Nation youth in Canada had the highest rates of adolescent suicide of any population in the world. And researchers went to 196 First Nation communities, and they were stunned to find that although the group has the highest rates of suicide, a number of the communities, about half of them, had had no suicides at all in the last 5 years. And they asked, what makes the difference? Those communities that were challenging the government of Canada to titles to the land of Indigenous people, to the right of self-government, to control over their services like police and education and fire, and having a building in the community where they taught their children their history and their culture. Each of these indicators of protest, advocacy, and empowerment was associated with a lower risk of suicide, and they found a dose-response relationship. The more of those indicators of advocacy, protest, empowerment present, the lower the risk of suicide, because it was giving those young people a reason to live and telling them they can make a difference in society. So here is another resource. But we also need to move further upstream. We need to implement policies to reduce all of these negative effects of segregation and other upstream mechanisms. So we need to do what I call in a paper I wrote with Lisa Cooper, we need to create communities of opportunity to minimize, neutralize, and dismantle the systems of racism that create inequities in health. And we lay out in that paper a broad range of strategies. In the interest of time, I'll talk only about 2 of them. Investing in early childhood and improving neighborhood and housing conditions, but improving income and access to employment, all of these are powerful strategies. Investing in early childhood, I'm picking an example that comes from right next door. In Chapel Hill, the Carolina Abecedarian Project is famous globally. People come from around the world to study this project. What happened in this project? They took poor kids, 80% of them African American, and at birth, randomized them to receive early childhood intervention, which was placed them in a nurturing environment with good nutrition, good pediatric care, good intellectual stimulation. Birth through 5, that's all it was. By age 21, those who had gotten the program compared to the control group, better mental health, lower drug use, more active lifestyle, greater academic success, greater vocational success. By the mid-30s, of intervention, just birth through 5, by the mid-30s, markedly lower levels of risk of cardiovascular disease and metabolic disease. Here are the systolic blood pressure differences between those in the treatment group, those who got the program, compared to the control group. Dramatic effects, and studies reveal that these interventions literally save society money. Every dollar invested in one study done in Michigan leads to a $17 return to society. Communities of opportunity also need to improve neighborhood and housing conditions. The Move into Opportunity is an example of a project that took people living in public housing, by the flip of a coin, allowed some of them to move to not optimal housing, but less poor housing, housing with lower rates of poverty. 10 to 15 years later, no health intervention. All you did was change the neighborhood. 10 to 15 years later, lower levels of obesity, lower levels of severe obesity, lower diabetes risk, just by changing the neighborhood. Now, many people say, well, but it's too hard to do, we cannot do it. So I want to leave you with one example, Atlanta's East Lake District, purpose-built communities of what is possible in the United States. So come with me to East Lake Meadows in Atlanta in 1995, a disadvantaged, public housing project, very high rate of crime, very dilapidated housing, only 13% of adults employed. The elementary school was one of the worst performing in the state of Georgia. Come with me to the villages of East Lake. I visited it about 5 years ago. 90% reduction in violent crime. Mixed income housing, 50% of the residents qualify for public housing, 50% at market rate. All able-bodied adults are employed, and the school, although 60% of the students qualify for reduced price meals, the school is one of the top performing in the state of Georgia. What the purpose-built model shows is that it can be done. It is possible to address all of the challenges that poor communities face simultaneously. It's possible to provide integrated place-based solutions to develop high-quality education for poor kids and have quality mixed-income housing and put a set of wraparound services. You can see Shirley Franklin, the former mayor of Atlanta, is the chair of the board of purpose-built communities, and there are 25 communities in the United States that is replicating the model. And purpose-built will provide free technical assistance to any community who wants to replicate their model. So it can be done. So let's bring the Christian piece of my talk into focus. Where is contemporary Christianity on issues of racial equity? Here is a 2021 study from PRRI, and what it finds, this is the percent of Americans agreeing that the United States has made great progress, that's the actual words in the question, in achieving true racial equity. And you can see large numbers of Americans believe that that is in fact true. So that I showed you the differences by race. Let's look at the differences by religion. 29% of black Protestants believe the US has made great progress in achieving racial equity. 36% of the religiously unaffiliated, 48% of white Catholics, 51% of white mainline Protestants, 54% of white evangelical Protestants. So a lot of Christian people feel that the problem of race has been solved in the United States. It points to three challenges we have: to build awareness levels of the challenges that still persist, to build empathy so we care about the problems that people face, and empathy and positive emotions are critical determinants to build the political will so that we have the support to implement the policies that would address the determinants of health. And I say to contemporary Christians who claim to follow Christ, that Christ said that this is how you know if you're truly a follower of his or not. Because I was hungry, and you gave me something to eat. I was thirsty, and you gave me something to drink. I was a stranger. That's an old English word. I was an immigrant, and you invited me in. I was naked, and you clothed me. I was sick, and you visited me. I was in prison, and you came unto me. So for Christians, the Bible pictures a great judgment day, and the final decision turns on one point. What have you done or failed to do for him in the person of the poor and the disadvantaged? Desmond Tutu says, if you are neutral in situations of injustice, you have chosen the side of the oppressor. So what is holding us back? What's the elephant in the room? Religion and prejudice. How are those two phenomena related? There's a large body of research, I'll show you a couple studies tonight, that has consistently found that a lot of religious people are more intolerant than the non-religious. Give you one example of a study I was involved with. We did a large national sample and general social survey of American adults. One of the questions we asked people, well, two of the questions was how religious they were and how spiritual they were. And a lot of Americans, 52%, unlike the way many scholars think about religion and spirituality, more than half of all American adults said they are very religious and very spiritual. They don't see a distinction between the two. 10% said it was spiritual only, 9% religious only, 29% neither religious or spiritual. The spiritual and religious people had the best profile on a number of indicators. They attended services more frequently, prayed more often, meditated more, read the Bible, had more daily spiritual experiences, were less distressed and less mistrusting. However, the spiritual and religious adults had the highest levels of intolerance. We gave them an intolerance scale, their beliefs about atheists, racists, militarists, communists, homosexuals. They were the most intolerant. And it's not just a global intolerance. Here is a book published in 1973 that summarized the research in the United States on religion and racial prejudice. It's called Bias and the Pious. The early research found that religious people were more likely to be racially prejudiced than non-religious. The more frequently they attended services, the more prejudice. The greater the orthodoxy of their religious beliefs, the more prejudice. However, subsequent research indicated it was more complex, that extrinsically religious people were more prejudiced, but intrinsically religious people were less prejudiced. What's extrinsic religion? Extrinsic religion is a religion that is utilitarian, that's rules-oriented, that's legalistic. The problem in America is that, this is what the national data shows, is that most religious people are extrinsic. But intrinsically religious people, and that is where religious beliefs are central to who you are. They are meaningful to you. They are integrated into your worldview. They shape everything you do in life. Intrinsically religious people are less prejudiced. But if you don't make the distinction, the extrinsic religious are so much more common that they overwhelm the pattern. Other recent research finds that, yes, it's the type of religious orientation that people have. They call it a fundamentalist orientation. I'm not talking about fundamentalists in a theological sense, in a psychological sense. People who have a rigid, closed-minded worldview, who believe that their religious beliefs are 100% correct, is predictive of higher levels of racial prejudice. What seems to be important is not the content of the religious beliefs, but the inflexibility in which they hold their beliefs. So what can religious people do about the challenges we are talking about? Well, religious institutions and leaders can raise awareness levels of the striking social inequities that give rise to inequities in health and multiple other domains of life. Religious institutions can uplift solutions and be agents of social change. Churches can develop programs and enhance members' and communities' knowledge of food and fitness and sleep and encourage healthy choices. They can also be advocates for justice and equality. They can offer programs and outreach services to low-income persons to ensure they have a marketable trade or skill to earn adequate income or support good health. Members can volunteer and make a difference in the community, serving the least of these. They can spend time with people in distress. They can become informed about social needs in their community and make the love of God real to people in their community. There are opportunities that are consistent with the beliefs of religious people. I want to give you a couple examples of churches coming together to promote health. Last week I was in New Jersey and I met Reverend David Jefferson, Sr. He's the pastor of the Metropolitan Church in Newark, New Jersey, and he did an amazing job in dealing with COVID-19. He organized some African-American pastors, 10 of them, to collaborate together to fight against COVID-19. They placed a community navigator in each church, which provided information locally to the members. All those 10 pastors got vaccinated for COVID-19 live on television. So all their community could see they were getting the vaccine. They had a Mother's Day program, and they combined flowers for the moms with getting the moms vaccinated. They worked closely with the local community health center, which had an ice cream truck at vaccination sites. So it's just amazing what you can do if you've been creative. Here is an example from North Carolina. Faithful Families in North Carolina, a group that came together in 2007 and developed a curriculum for local churches that included a planning guide that focused not only on individual behavior, but focused on policies that could be implemented and environmental change. So for example, having the churches agree that they will build physical activity into all of their events, and they will serve water and fresh fruits at all of their events, giving healthy choices an option. Since 2007, Faithful Families have implemented this in 45 different communities. They have provided curriculum to hundreds of individuals. Faith communities have committed to more than 170 policy and environmental changes, the most common to serve water and healthy options at all meetings and events. But I want to say religious organizations need to do more. They need to intentionally spur compassion, engender empathy, and facilitate the development of political will for sustained action to initiate and maintain social justice. W.E.B. Du Bois, a great African-American scholar of the late 19th century, published a book in 1899 called The Philadelphia Negro. In the book called The Philadelphia Negro, he has a chapter on Negro health. He documents the racial disparities in health that existed back then. And towards the end of the chapter, he penned these words: "The most difficult social problem in the matter of Negro health is what he called the peculiar attitude of the nation toward the well-being of the race." And he says there have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference. What he calls peculiar indifference simply means we don't care. Scholars today call it the empathy gap. And studies on every continent shows there is a racial gap in empathy. We feel the pain and suffering of someone of our own group compared to someone of a different group. And here is a sobering study looking at the empathy gap among white children in the United States. At age 5, age 7, age 10, they stick someone with a needle and they have randomly persons of different races, and they ask the child to report how much pain you think that person is suffering. And at age 5, white children show no racial gap in empathy. By age 7, there's a tendency. By age 10, it is pronounced. So we have work to do in terms of building sympathy and building the empathy. I want to leave you as I close with an important point to keep in mind. The policies I'm talking about that would benefit African Americans and other disadvantaged populations will benefit all populations in the United States. Do you know there are almost twice as many poor white people as poor African Americans in America? The rate of poverty is higher for blacks, but there are about nearly 16 million poor whites compared to about 8.5 million poor African Americans. So if we can create these communities of opportunity, we can help all races. I leave you with two quotations tonight. Martin Luther King said, "True compassion is more than flinging a coin to a beggar. It understands that an edifice which produces beggars needs restructuring." I have been talking about edifices that produce beggars. We need to make a commitment to restructure them. And finally, I leave you with the words of Robert Kennedy. Speaking in South Africa in the 1960s in Cape Town, South Africa, during the dark days of apartheid, he says, "Each time a man or woman stands up for an ideal, or acts to improve the lot of others, or strikes out against injustice, he or she sends forth a tiny ripple of hope. And those ripples can build a current which can sweep down the mightiest walls of oppression and resistance." Dr. Payne had many ripples of hope, had tidal waves of hope. It is my hope that each one of us tonight, as we think of his life and his impact, will make a commitment that we will be a tiny ripple of hope And together, we can build a current that can sweep down the mightiest walls of oppression and resistance. Thank you so very much.
I think the first thing that comes to my mind is wow. Right. Thank you so much, Dr. Williams, for your lecture this evening, for your research, the work that you have put in, and the challenge, the profound challenge that you have left us with. As I was listening to your presentation with all the challenges and the larger systemic drivers upstream that's affecting those social determinants of health, I'm thinking, wow, this is can be overwhelming, all right, for a lot of people. But this localized focus here in terms of being these little ripples of hope, and my little bit with your little bit with somebody else's little bit, can make a huge difference. So thank you so much for that. I did want to ask one question. I know we have limited time here before we transition, but I just want to maybe, before we open it up to others who may have questions, and so as you're thinking about, if you have questions, think about that, and we'll turn those over to Dr. Williams. I just want to pick up on one piece here as you talked about this empathy gap, right? Just getting people to care. And I've taught with a lot of students over the years in teaching social ethics and sharing some of the data from your work. And inevitably, I'll have students from particular religious communities, maybe many of those communities that you were referring to, that may have a psychological disposition of like fundamentalism, and they will come to me and they would say, well, Dr. Smith, I think a lot of this is right. I think this can be rooted in their understanding of biblical tradition that is wrong. We need to do something about it. But one of the challenges they keep saying is that how do we get our people to care, because they recognize that many in their context will not. What would you say to those students in light of what you presented to us?
Really, really good question. One of the things that's necessary to reduce the empathy gap is to identify with the pain and suffering from others. What's most effective, in spite of all the statistics I've shown you tonight, is not statistics. It's narrative. To find examples of stories that people can relate to and can feel because they can connect with the pain and suffering from others. There's a lot of research by psychologists who study empathy that find that sometimes, even with the description of the same story, slight changes to the wording can make a difference in helping people to emotionally connect with it. It's an area of research. It's not my area of research, but it's an area of work that can be done. There's an example of a study published in Science that looked at transgender individuals and sent canvassers out to the community, and they followed a particular script. And the goal of the script was the canvasser to get the potential voter they're talking to imagine a time in their life when they had been unfairly treated so that they could empathize with the plight of transgender individuals. And what they found, it worked. The canvasser just did some prompts but let the person do most of the speaking, and it reduced their prejudice towards transgender individuals. It increased their commitment to vote for this law that would provide some protections for transgender individuals. It worked whether the person was Democrat or Republican. It worked whether the canvasser was transgender or not. The stunning thing about that study, there was a commentary in Science published with the study that said the organization that developed the script tested 13,000 conversations before they found one that had the right language that worked. It's mind-boggling to me to imagine testing 13,000 conversations. I can't wrap my brain around it. But it does reflect the kind of commitment we need to make. But what the generic issue we know is how can you help people to feel that they are walking in the shoes of someone else so they can empathize and they can feel the pain that others feel?
Wow, great. Well, thank you. I know we had a wonderful, wide-ranging conversation this afternoon, which was wonderful, and I do want to open it up to others who may have questions or comments for Dr. Williams at this time. And CJ has a microphone, so if you can just raise your hand, and we'll call on you there. Great. Yeah, Martha.
Thank you, Dr. Williams, for your work and these words. And this is maybe a question for both of you about like the field of narrative ethics and why we undervalue and underuse that for just these reasons. And what does that say about sort of privileged places and how we operate?
I don't know much about the field of narrative ethics, so I defer to you.
Yeah, no, I think I think the point that you're making is absolutely right. I don't know if Dr. Jeff Baker is here or not, but he's a medical historian, and one of the things he often says is that you combat bad stories with better stories, right? And I think that's true, and I think that narrative ethics actually can be a way of fleshing out the details of people's lives, that we don't have these abstract, disembodied persons, but we know that we're individuals who are in real life communities, and oftentimes there are these various touch points of people's lives from different backgrounds, oftentimes where we think that we are completely different, right? And those little markers at times can be a way of kind of generating empathy, I think, in many respects. It's just one of those conversations. I think it really builds off of what Dr. Williams was saying about the importance of story and narrative to help bridge some of these gaps, yeah. So I do think it's something that's worth exploring, yeah, absolutely. Thank you.
See a question?
Yes, CJ, right over here, yeah.
And then one over here.
Hi. Do you think that I'm thinking about what you talked about empathy and people needing to develop it. We are bombarded with requests for money, for this, for that, for the other, and do you think that it has sort of dulled the empathy that, was even there?
To be honest with you,
there's just so much bombardment of it, the internet, the mail.
Fatigue, yeah.
But we do have the empathy. When there's a made-for-television disaster, when we see a cyclone out in some part of the world and we see people suffering, Americans are texting money on their cell phones, they are responding because it's a made-for-TV. We see it, we feel the pain, we sympathize, and we act. So I think the empathy gap, the racial gap in empathy, is found on every continent. This is not a US phenomenon. It's found on every continent. So I think it's a real phenomenon. The trick is, how can we tell the story, and it is story, it is narrative, in a way that helps us? You see, we all have what Frameworks Institute called dominant frameworks that we use to interpret. So I didn't talk about it, but there's research that shows the dominant framework, more than half of whites in the United States believe that all racial inequities would be eliminated if blacks simply worked harder. It's the laziness of blacks that's responsible for racial inequities. There's national data. I didn't bring the slides, but they exist. The same, you can find them online. Public Research Institute, you can find their data online. So it's like, to the extent that you have dominant frameworks that shape how you interpret incidents, so you have to find a way to break through those dominant frameworks by telling a story that draws that person in and gives them a whole new understanding, and now they'll feel empathy for the challenges that person faces.
Yes, sir. Oh, I'm sorry.
Right here, too. I thought there was one over here.
Good evening. First of all, I want to thank you for such a wonderful and comprehensive presentation. This kind of as I was listening to the presentation, it just kind of touched me and reminded me of the importance of data collection and making informed decisions and how we can make improvements in our society. So, you hear a lot about voting and how you can make a difference, but I guess my comment or question is, how maybe you can offer some comments on how certain, I guess, minorities, African Americans, the importance of participation in studies, offering up, vulnerable, often sensitive things about their backgrounds, their lifestyles, in efforts to help people and make informed decisions going forward.
That's a really good point. I'm glad you raised the question. There's no question that there is reluctance among poor people, among multiple disadvantaged racial and ethnic groups in this country to participate in clinical trials and other studies. And it is driven by two things. One is the history of what has happened before. There's been forced sterilization in many states of poor women and women on welfare and minority women. There's been forced sterilization of Latinas in Puerto Rico and in Guatemala and in other countries that were led by the United States government and US researchers. So there's a history. And of course, there's a Tuskegee syphilis study and Henrietta Lacks. We can keep going on. There's so many examples. But for many poor people and populations of color, it's not Tuskegee that drives them and drives their reluctance. It's the way they have been treated within the healthcare system. It's what has happened in their life. And that's what the research shows. It's not that some of them are unaware of the history, but they know how they've been treated. And if people have treated you badly and haven't treated you with dignity and respect and haven't acted as if they have your best interests in mind, why are they going to trust you? And so we have work to do to build the trust. The work of Tom Leviste and others shows that if you work with those communities, spend time with them, listen to them, talk to them, explain what is being done, why it is being done, and how it's beneficial, they want what's good too. But it's oftentimes may take more than one visit, because how do they know that you're speaking the truth the first time you come around? So it's really about building relationship and building trust over time, but part of the reluctance is linked to historical factors for some, but for others, the research suggests that even in the context of the COVID-19 vaccine, that much of the reluctance is linked to how people have been treated, and therefore they don't trust the system, and they don't trust providers who are saying this is going to benefit you. So that we have work to do to build those bridges.
I am in the unenviable position because I feel the eyes of my colleagues, right, who wanted me to keep time, looking down upon me, right, to close down the Q&A, because we do have one announcement after we are done today, and I have to take that on my chin, so I'll hear from you guys, which is okay. But I do want to thank Dr. Williams for being here and just joining, welcoming him. Thank you so very much. And I want to thank you for coming, so give yourselves a round of applause for making this a wonderful evening for us with our inaugural lecture, Richard Payne Lecture in Faith, Justice, and Leadership. And Dr. Warren Kinghorn, will you please come?
I echo Dr. Smith. Wow. Thank you so much, Dr. Williams, for what you brought to us tonight, for what you challenged us as a Christian, as a white Christian. I particularly feel the challenge that you've offered, and just am really grateful for your presence here. Thank you very much for being with us at this inaugural Richard Payne Lecture. We're really grateful. Thank you. I want to just offer a couple of housekeeping details as we finish. First is to thank all of you for coming out tonight. Many who plan events like this have noted that after COVID, it's always unclear who's ever going to turn out at a live event. And so to see this room so full and full of life is such a blessing. Thank you to all of you in the room who have donated to the Richard Payne Program Fund, which has helped make this lecture possible. If any of you are interested in giving to the fund, there are some donation information cards available at the table outside, where you can also find the TMC flyers that I mentioned earlier. Also, we know that many of you may wish to greet Dr. Williams and also Mrs. Terry Payne. They do have another event to get to soon, so we're going to escort them to the lobby right outside the chapel. They'll remain there for just a few minutes, and then they'll have to move on to their next event. So we appreciate your understanding in that regard. Again, thank you to Dr. Williams. Thank you to all of the Payne family and friends, and Mrs. Payne are here today. Thanks to all of you for being here tonight. Go in peace. Thank you.